Hi, good evening. Thank you for that introduction. I am Dr. Holly Sheldon, and this is Dr. Kutayli, and we are excited to talk to you in Colorectal Awareness Month about something very near and dear to our heart, which is colorectal cancer. I have nothing to disclose. By means of introduction, I joined Baystate Medical Center in 2015 by way of New Jersey, where I completed my colorectal fellowship. I do consider myself a transplant Bostonian, having the privilege to continue my training at Boston Medical Center and at Boston College. And I am board certified general surgeon and colorectal surgeon. I had an interesting conversation. I try to call my mom on every drive home. I have a fairly lengthy commute, and it was last Friday. I was driving home after a fairly long day in the operating room, and she said to me, "Hey, do you know what type of cancer is one of the fastest growing in young adults?" And for a moment, I had to pause, and I was like, "Oh my gosh, even my mother is testing me about work on my drive home." And I reflected on a recent publication by the American Cancer Society and actually a fair amount of news recently about this very thing. And the answer to her question that I thought she was really pressing me on is that colorectal cancer is actually one of the fastest growing cancers, particularly in people under the age of 50. And that's what I'm trying to show here in this graph, is that we see overall, thankfully, the incidence of colorectal cancer is decreasing among all comers, especially those greater than 50. But if we take a subset of the population from 20 to 49, that we can see that there's been increasing rates of colorectal cancer, and somewhat more concerning, we're seeing that there's locally advanced cancers, meaning higher stages of cancer, particularly in this population. And so Dr. Kutayli and myself are really honored to be here this evening in March, which is Colorectal Cancer Awareness Month, to talk about a disease that can be preventable, treatable, and even beatable. By means of just some background information, when we look at all cancer diagnoses in men and women, we see that breast and prostate cancer are number one, followed closely by lung cancer, and then a very close third is colon and rectal cancer. But interestingly, colorectal cancer is actually the second leading cause of cancer deaths in the United States. And this is important because every 7 seconds, someone in the United States turns 45. And as we'll allude to throughout the presentation, that's an important age. And every 3.5 minutes, someone in the world is diagnosed with colorectal cancer. And just over the course of this discussion this evening, there'll be 20 new colorectal cancer diagnoses in the world. Every 9 minutes, there's a death from colorectal cancer. And this has been really palpable in pop culture recently with the passing of Christy Alley after a short bout with metastatic colon cancer. And as I'm trying to show here, colon cancer is a disease of men and women, young and old, and really there are no race or ethnicity barriers affecting Stuart Scott, one of my all-time favorites from ESPN, Chadwick Boseman from Black Panther, who really gained some attention in the past few years. And then obviously Ruth Bader Ginsburg, who had many cancers, but also was treated for colorectal cancer. It's important because we have very good modalities that allows us to not only screen for colorectal cancer, but can be therapeutic in terms of treating and even preventing the development of colorectal cancer. But every 5 seconds, someone who should undergo a colonoscopy and screen for colorectal cancer does not undergo this. And this is important because the literature suggests that colonoscopy alone can reduce the incidence of colorectal cancer by 60 to 90%. And I think many of us, if we knew that we could have risk reduction by that significant amount, would undertake that for anything that we could prevent in our lives. And so really at the end of the day, there's no ifs, ands, or buts, something near and dear to our hearts. You should schedule your colonoscopy. Tonight, I'm going to cover some of the basics, including structure and function of the colon. We're going to be talking about the difference between cancer and what is a polyp. We've already touched on some of the important statistics regarding colorectal cancer and risk factors. We'll talk about signs and symptoms, and then I'll turn it over to Dr. Kutayli, who's going to talk about evaluation and treatment for colon and rectal cancer. If we think of the digestive system, not a lot of people like to talk about it. I know when I tell people I'm a colorectal surgeon, there's a lot of hushed tones, and my partner doesn't like to give that information away. But the digestive system is incredibly important. It's important in terms of making nutrients and creating energy for our body. We think of the food that we take in. Fiber is the breakdown product once the food has been digested. And an important part of this system is the bacteria that actually live in our gut. And I'm going to come back to this in a little bit because there's a lot of emerging research regarding what we refer to as the gut microbiome or microbiota and its relationship to diseases. And the digestive system actually has its own brain. I like to think of my organ, the colon, rectum, and anus as really the driving portion of the human body, but it does have its own mini brain that helps aid in many of these functions. And so this is just a picture that represents the digestive system from the mouth to the anus. If we think of the process of eating a hamburger, you ingest the hamburger, starting actually as soon as the mouth and the esophagus. It's involved in breaking that down. I like to use the analogy of breaking this down into sliders. I feel like as a vegetarian, I have free will to use the example of a hamburger. It ends up in the stomach, further breaking this down, starting the digestion process. Again, the analogy that I use is meatballs. I actually think Dr. Kutayli has told me never to equate food to the digestive system, but sorry, that didn't rub off on me. It's further broken down as it travels through the small intestines. The process is really taking the large product and breaking it down and really turning it in to a liquid like a smoothie, and it delivers it to the colon. And as it moves throughout the colon, it extracts the nutrients and water, eventually leading to what we know as stool. I like to think of this process as really a refined sort of recycling center where we take the hamburger and we recycle it out into the useful nutrients. But really, the large intestine is much more sophisticated than that. The large intestine, which is the end portion of the digestive system, the large bowel is smaller than the small bowel. What we refer to as the large bowel actually refers to the diameter of the colon. There's approximately 5 feet of colon versus 16 feet of small intestines. And it can take 12 to 48 hours, depending on many factors, for the food that we have eaten to eventually reach the rectum, which is the reservoir before it exits the body. And again, there are over 1 trillion microscopic organisms that live in our colon. As means of a brief introduction to anatomy, I often say that I'm merely a simple proctologist, but as the food enters the first part of the colon, it's called the ascending colon because a stool is moving upwards. It travels across the transverse colon before heading down the descending colon and S-ing around in the specialized portion of the sigmoid colon. It's then stored in the rectum, before leaving through the anus. And the blood supply is critically important to the colon, and that's what I'm trying to represent here. This actually helps dictate many of our cancer operations, which Dr. Kutayli will touch on in the next portion of this talk. But within this envelope that contains the blood supply are the lymph nodes. And the lymph nodes are really the filtration system of the body, but they're also important as a means for patients with cancers, that if there is spread or metastases of that cancer, it can occur by way of the blood vessels and the lymphatic system. Again, the large bowel or the large intestine is important in recycling and reusing nutrients. It's important in absorption of water. The homeostasis refers to a balance within the colon, and that balance that we talk about is of good and bad bacteria. And disruptions in that balance can actually lead to several disease processes, including inflammatory bowel disease, colon cancers, and what we also talk about as C. diff colitis, or an infection that can cause diarrhea. The colon, and specifically the rectum, is a reservoir. It holds on to stool until an appropriate time for evacuation. It has the ability to discriminate between solid, liquid, and gas, and then obviously is involved in the process of evacuation. And so this is really a very, specialized and highly intelligent kind of organ system in the body. Important to this is the epithelium, or the lining of the colon. If we were able to section the colon and look at it under a microscope, that's what we see here on the right-hand side. This is kind of the inside, or the lumen of the colon, and that specialized kind of sawtooth appearance to what we call the mucosa increases the absorptive capacity of the colon. It can absorb, as we talked about, salt and water and short-chain fatty acids, and it usually absorbs about 90% of all the water that is given to large intestines. It secretes mucus to help pass it through the gastrointestinal tract. I often, for patients who know me, I describe the colon as a sponge. It absorbs all that water, but it does have a certain limit, and that water that remains in the colon can help dictate really the consistency of the stools. As it moves quicker through the gastrointestinal tract, the colon doesn't have the ability to absorb the water, and that can often lead to diarrhea. The microbiome, which I referred to earlier, is the individual's diverse community of organisms that live in the body. And, it's probably a little bit of hyperbole to say that it's as unique as a fingerprint, but everyone's makeup of the gut bacteria tends to be a little bit different. Probiotics, something that we commonly, you can get on the shelf at any pharmacy or grocery store, is something that patients commonly ask us about. It's usually a combination of good and of bacteria and yeast, and it helps reconstitute or reestablish the balance of those bacteria. And as I mentioned, it's important in immune function. It helps create vitamins, and it has several anti-inflammatory properties. And research within the past decade has pointed to its importance in the development of disease. We know that the balance of certain bacteria, of both good and bad, can lead to autoimmune disorders, including inflammatory bowel disease. It can lead to obesity, and in children, it can has been thought to be related to necrotizing enterocolitis. And then why we're here today is this, to discuss its role in colorectal cancers. And there's research on the horizon that has been able to look specifically at the distribution of good and bad bacteria and offer some predictions about risk. Its other importance are included in terms of diabetes resistance, vitamin formation, and absorption of food. And so really the gastrointestinal tract is much more than just a dump truck. I think of my little 7-year-old, and I think of, that kind of tricked out dump truck that is highly specialized. But as specialized as the colon is, things can go wrong. And we often have patients ask us, well, what are colon polyps? And colon polyps are merely just small clumps of cells that form in the lining of the colon. That lining that I alluded to earlier regenerates itself every 4 to 5 days. And that during that process, cells can grow abnormally quickly, and this disruption or dysregulation in the process of regeneration can lead to the formation of polyps, as shown here. The transition from a very benign appearing polyp to a cancer usually takes on the order of 7 to 10 years. And research has been done in the early 90s that have mapped out some of the sequences of this process. I like to refer to colon polyps kind of like ice cream. My bad habit of talking about colon and rectal surgery and food. But just as there are many different types of ice cream, there are many different types of polyps. In polyps, the 5 most common types are shown here in this diagram. Inflammatory polyps are typically seen in the setting of inflammatory bowel disease. They're usually due to a reaction to local irritation. They can be removed during colonoscopy, but they have very little risk of transformation into a colon cancer. Additionally, hyperplastic polyps are typically found in the very last part of the intestines. They're usually small. And again, they usually do not have any or very low risk of developing into a cancer. The most common types of polyps that you may see when you have a colonoscopy is called a tubular adenoma. That's 70% of the polyps. Most of them do not become a cancer, but the concern is if left unattended, they can certainly become a cancer. And then within the adenomatous polyp, there are villus or tubulovillus adenomas and sessile serrated adenomas. And these polyps look a little bit different on the colonoscopy, and they have a greater potential to become cancer. And I think the takeaway point that not only there are different polyps, but that the treatment for this is most commonly during a colonoscopy is that we can remove these polyps, and that's how we reduce the risk of their transformation or changing into a cancer. I alluded to this slightly earlier. The adenoma or polyp to cancer sequence has been well described in the literature. And I think the important takeaway point is that the transition from normal lining of the colon to a cancer has many sequences that involve mutation or changes in genes that help kind of facilitate this process. And we can detect these changes in tumor specimens that we have. Colonoscopy is associated with polyp removal. And again, it's important because this is how we reduce risk. So what are some risk factors for polyps? There are both modifiable, meaning we can change this risk, and non-modifiable risk factors. Some of the more common ones are tobacco use, obesity, and certainly diet. And if we reflect back to that very early slide in my conversation with my mother, we think that some of the increased risk of colon cancer is likely attributed, at least in part, to increasing rates of obesity, sedentary lifestyle, and tobacco use. Non-modifiable risk factors, meaning we can't change this, is typically family history of colon cancers, inflammatory bowel disease, and radiation exposure. Hereditary cancer systems represent a very small subset of colorectal cancers, somewhere on the order of 10 to 15%. We know that as we age, the risk of polyps become more common. There is a slight gender prevalence. And then we know that there's increasing rates of cancer and polyp formation in certain ethnicities. Comorbidities such as diabetes and autoimmune suppression also have a slight increase in risk. And likely the diabetes harkens back to it being multifactorial in this metabolic syndrome. So if we know what may cause polyp formation, is there a way that we can prevent polyp formations? And certainly a healthy diet high in fruits and vegetables and fiber is really important. Maintaining a healthy weight and physical activity are certainly important. And there's been some research within the last 5 to 10 years regarding this idea of chemoprevention, or can I take a supplement or a medication to help prevent polyps? And I would say in this list here are probably 5 of the more common medications available that have some weaker evidence suggesting their role in polyp prevention. Probably the most common one is aspirin. And this was born out of the literature that looked at its reduction in cardiovascular risk. And when they looked at this population who started low-dose aspirin at an early age, they they saw that there was a reduced risk of polyp and cancer formation. The same thing can be seen for our COX-2 inhibitors. It's a form of NSAIDs or non-aspirin. The problem was the side effects, including increased bleeding and cardiovascular impacts for patients who were taking these medications, which were removed from the market. And then folic acid, calcium, and vitamin D our primary care physicians will commonly look at vitamin D level and calcium levels. And there's some suggestion that these three vitamins can be important in reducing risk. And the reason for that is shown in this slide, in which we can see that aspirin, folate, and calcium actually impact this transition from normal epithelium to the hyperproliferative or fastly growing epithelium, likely by some impact on these specific gene mutations. And so when we talk about colorectal cancer, it was, I would say, within the last 5 years that the National Cancer Institute came out with a hallmark paper that was looking at the incidences of colorectal cancer in the United States. And they saw, as we have been talking about, that rates overall were declining, but there was really an alarming increase in cancer rates among those less than 50. And this is represented here in the graph. If we take patients with colon cancer, we can see that overall incidences in those less than 50 have really been increasing, despite the fact that cancer overall in those greater than 55 have been decreasing. And I mean no offense by listing greater than 55 as old, because I'm quickly approaching that as well. And we saw this same trend in rectal cancer, in which rates overall were increasing in those less than 50, while it was decreasing in the population greater than 50. And in fact, I saw recently in the American Cancer Society that nearly 20% of new diagnoses of colon cancer are in patients less than 50. And it was really based on this work that the American Cancer Society urged patients at age 45 to start screening for colon cancer. And so the age is no longer 50, but yet 45 for the average risk American. And in fact, Health New England, because a lot of our patients come in and ask, if the colonoscopy will be covered before age 50. And Health New England states in their description of covered services that colonoscopy is covered for members under the age of 45. And I think this is important. And so what type of clinical presentation do we have to think about? What are worrisome symptoms that you may be, questioning? Should I be worried? Should I seek medical care? And there are really, three patterns of presentation that we see. We see patients who come in with symptoms, meaning they come to our office or the primary care physician stating that they've had blood in their stool, they've had a change in their bowel habits, and these really need further evaluation. There is a subset of patients who on screening colonoscopy are found to have cancers. And then I would say the smallest proportion of our patients present emergently, meaning they're having significant and severe abdominal pain. There's been an obstruction from the cancer or a perforation, meaning a hole in the colon. Early stage cancers are most commonly asymptomatic. They're usually found on that screening colonoscopies. Tumors can certainly cause local symptoms, and we talked about this. 74% of the time, it's a change in bowel habits. Patients are noting that they're only having diarrhea, or they have a lot of leakage, or they're having significant difficulty moving their bowels. Very rarely would patients present with abdominal masses, and a fair amount of time, we see patients presenting with anemia or low red blood cell counts. And this is commonly picked up by the primary care physicians. And this is because colon cancers can shed red blood cells that we may not even be able to see into the stool. Symptoms can also be due to disease spread, meaning they can present with abdominal distension and right upper quadrant pain. And then there's some other unusual presentations of colon cancers that we can see. Patients with symptoms, unfortunately, typically present with more advanced disease states. And so it's really important that we can try to catch cancers early. And this is really the importance of screening for those polyps so that hopefully we can remove them, and undergoing your colonoscopies at age 45 for average risk individuals so that we can find cancers earlier, which significantly impacts prognosis. So how do we assess when a patient needs to undergo a colonoscopy? There are some standards. Typically, the American Society of Colorectal Surgeons and also for gastroenterologists have many algorithms that help us understand when a patient needs to undergo a colonoscopy. Most patients fall within this average risk. There's no history of cancers. There's no family history of polyps. And so we will begin those screenings at age 45. Patients or families with increased risk are those with a history of colon cancers or polyps. Certainly inflammatory bowel disease, meaning ulcerative colitis or Crohn's disease, should undergo screening at a sooner age. And then certainly there's other syndromes. There are some gynecologic cancers and breast cancers that can be associated with an increased risk of colon cancers. And so patients should commonly undergo screening earlier. I feel like I'm old enough to say back in the day, we used to say that if there's a personal history or a family history of colon cancer, if your loved one was diagnosed at age 45, we typically would screen at least 10 years before that diagnosis. And that reflects back on the fact that we think the average time from normal colonic lining to a cancer can take roughly 10 years. And, you know, a lot of talks have to address the impact of COVID-19, which we are arguably still seeing. And if we look at some of the three most common cancers, breast cancers, colon cancers, and cervical cancers, you can see here that with COVID-19, when this hit us in late 2019 and 2020, there was a drastic decrease in not only access, but for people seeking routine screenings. And you can see how there's, we had been roughly around 3,000 screenings a week for colon cancer, and this dropped drastically. And with that, what we saw was that there was an excess rate of breast and colon cancer deaths per year. And this is due to delayed diagnosis and advanced disease progression. But also what we saw as an impact of COVID is that while people weren't getting their colonoscopies, they were relying on additional adjuncts, which I'll talk about in a little bit. So colonoscopy is one of the better screening modalities, but there are stool-based tests that can be done at home to assess risk, and that patients starting in March of 2020 really relied more heavily on these screening modalities. When I say screening, what I mean by that, it's the process of looking for cancers in patients that are without symptoms. Screening tests can be stool-based, typically less invasive, done at home. And then there's the visual or structural evaluations, and that refers to colonoscopy and CT colonography. Stool-based test, there is the fecal immunochemical test. It tends to be inexpensive, and what it's doing is it's looking for markers of human blood in stool. This is typically repeated yearly. It's not impacted by food or drugs, which some of the more earlier stool-based testing is. But if you have a positive, what we call FIT test, this necessitates evaluation typically with colonoscopy. The fecal occult blood test, it has some ability to detect blood in the stool, but it is often impacted by dietary and medication alterations, and it's not specific to human blood, meaning high red meat intake can certainly lead to a false positive test. It also doesn't discriminate between the lower GI tract and the upper GI tract, and all of these are repeated on a yearly basis. Becoming popular, I would say, really since probably COVID-19, is something called Cologuard. This is a stool DNA test. It is covered by Medicaid and Medicare. It is FDA approved. It's a simple test. Basically, Cologuard sends you a kit with everything that you need. You collect a stool sample at home and you package it up very nicely to send it back to Cologuard, in which they're looking for the presence of blood and altered DNA in the stool specimen. It does not require a prep. There are no dietary modifications, and it has decent sensitivity, meaning decent ability to pick up the presence of colorectal cancer. And so if the Cologuard is positive, and I have had some of my patients refer to me saying, I did the Cologuard and it's positive, what do I do now? It often leads to a colonoscopy. And this is a study that was comparing Cologuard to the other stool-based studies, looking at their ability to detect cancers, in which Cologuard, has a sensitivity to detect 92% of cancers compared to the other stool-based test. But in terms of its ability to detect polyps, it tends to be much lower. So on the order of 40 to 70%. So decent at picking up cancers, but a lower ability to detect precancerous polyps. And there are certain situations in which many would not recommend or advocate for Cologuard or other stool-based tests, that being inflammatory bowel disease, personal history of cancers, hereditary polyposis type syndromes, or other worrisome findings. And that's merely because the probability of finding an advanced polyp or cancer becomes much higher, and therefore we really rely on colonoscopy. Colonoscopy is one of the gold standards for the visual exam, meaning the ability to actually look at the lining of the colon. It does require a bowel prep. When there is stool staining the lining, it becomes very difficult to detect very small polyps. It can be done both with and without anesthesia. I will say many people come with a fear of a pain or discomfort. And even some patients are worried about the embarrassment. And I will tell you that with anesthesia, my overwhelming sentiment that I hear from patients is, quote, "That was the best sleep of my life. Can I do it next week?" I usually hear that from a lot of mothers, and I, having personal experience with colonoscopy, I certainly understand that. Colonoscopy is diagnostic and therapeutic, meaning it has the ability to not only detect polyps and cancers, but can also remove them. And the complication rates from colonoscopies is really low. It's less than 1%, and it's covered by all insurances. CT colonoscopy or colonography is a way in radiology that we can try to look for polyps. People tend to say, "Oh, I want to have this done in radiology," but you still need a bowel prep to clean the colon, and it still requires insertion of a catheter to insufflate or to blow up the colon so that it can be visualized on the CT scan. It has a possibility to miss small and flat polyps, and it is sometimes not covered by insurance tests. And I don't want to encroach entirely upon Dr. Kutayli's time, but this just looks at sensitivity or the ability to pick up polyps of all sizes and its sensitivity for colon cancer. And you can see that colonoscopy is very good. But as we looked at some of these other adjuncts, the ability to detect very small polyps or cancers is much smaller. And this is the Cologuard, which again has a very good ability to pick up cancers. But if our goal is prevention, the ability for the Cologuard to detect polyps is much smaller. This is what many people think of when they think of how I'm going to prep for my colonoscopy. But this is actually what at least our practice does. It's 64 ounces of Gatorade in a bottle of Miralax. It tends to be well tolerated. It's not terrible tasting, and actually the prep is not bad at all. There are several myths, and I will go through these quickly in lieu of time, but the colonoscopy can wait, and I would argue that cancer does not take a break. I don't need one if I don't need symptoms. I already mentioned earlier that most cancers are asymptomatic. The prep is horrible. In fact, the prep is not horrible. It's gone are the days where we're consuming a gallon of poor tasting liquids. There's generally very minimal discomfort associated with the colonoscopy, especially when done in conjunction with our anesthesia providers. And people who say I'm not at risk of colon cancer, but everyone with a colon is at risk. I am a female and then less likely to get cancer, but gender does not impact screening recommendations. Colonoscopies are actually covered by most insurances. The risk is quite low, less than 1 in 1,000. And it's too embarrassing, but I'll tell you, every effort is made to be, for it to be comfortable and respectful. And at the end of the day, colon cancer can be prevented, or at least the risk of this can. And so in honor of National Colorectal Cancer Awareness Month, I urge you jump in, take the plunge, get your colonoscopies. And that if something is found on colonoscopy, to take a deep breath. We will get through this together as a team. And we do have a team of colorectal surgeons here and some of the best colleagues that I've had the opportunity to work with. And so at this time, I'm going to turn it over to Dr. Kutayli, who's going to talk about what happens when you are diagnosed with colon cancer.
All right. Well, thank you, Dr. Sheldon. You've done all the heavy lifting, actually, so I get to do the fun part now. Now that you've had the diagnosis of colon cancer and that's kind of been brought into your life, what do you do now? What next? Just by way of, getting the formal disclosure things. I don't have any financial disclosures. Hopefully you will be educated and maybe entertained. And I would be remiss if I said I did go to the Ohio State University, so I have to disclose that I am a Buckeye. And then I did my fellowship at Cleveland Clinic in Cleveland, Ohio. So I've also had the misfortune of being a Browns fan for a number of years before I moved to Massachusetts. And so some of the common questions that come up when somebody comes to us with a diagnosis of okay, I've got colon cancer, my doctor told me I have colon cancer. Some of the more common questions that we get are, what stage am I? That's the more often than not the first question. If the patient isn't asking it, they're maybe thinking it. Do I need a surgery for this? Well, I'm coming to see a surgeon, but do I really need a surgery, or what's going on? Are there other things than just major surgery that we can do? Will I have a bag or an ostomy? And usually you'll hear about ileostomy versus colostomy, and we'll talk about that here in a second. So again, common questions: what stage do I need a surgery? Will I have a bag or an ostomy? And then, what kind of life can I expect to have now that I have this diagnosis of cancer? What does that mean for me? And also, what does it mean for my family? And it's important to realize that, cancer is a multidisciplinary diagnosis, meaning that there's a whole cast of characters that are involved in the treatment of colon cancer. And it really stems from even the PCP, who might find the anemia on your routine labs, or might feel something on an exam, whether it's a rectal exam or some other exam. It's the GI doctor who might do your colonoscopy, who might find something. It's the surgeon who may get involved to do a surgery for this. The medical oncologist and radiation oncologist might need to be involved, depending on the location and the extent of the cancer, and we'll get into that in a little bit. But also the radiologist, who's going to read the different imaging studies that we get to help with the staging. The pathologist, who's reading the biopsies that we get and doing all the different kind of chemical tests on this. And then, if you are in need of an ostomy, we have specialized nursing, enterostomal therapy nurses who are specially trained to help with not only planning for an ostomy, but also helping with having an ostomy. And then obviously social workers, counselors, all of the case managers, all of the people who help us get the patients where they need to be and get them the help that they need. So George Foreman, this was attributed to George Foreman, I believe, is plan your work, then work your plan. And so the first thing we need to do is kind of figure out what it is that we're dealing with. So we want to go on its fact-finding mission to do our staging. And then once we kind of know what we're dealing with, then we'll start making a plan. And this plan is going to be different for everybody because there's no cookie cutter approach. We tailor every therapy modality to the patient, to specific patient needs, and then we have to just actually do the work of doing the therapies. So how do we stage colon cancer? Really, the staging of most cancers is through the TNM staging system, and T stands for tumor, where, what's the size of the tumor? Is it growing through the wall, or is it just a superficial polyp like Dr. Sheldon showed? The N stage is for nose. Did some of those cells start straggling out into the lymph node system, which she also showed a picture of, the lymphatic system. And then the M, which is metastasis. Did the cancer cells get out into the system and set up shop in other organs? And the most common place for colorectal cancer to do that would be the lungs and the liver, which is why part of our staging is we get CT scans to look at these things. So not to get too in the weeds about like actual staging, but what I tell patients is not to get hung up on staging. Staging is really a way for providers to talk amongst themselves about the location of cancer. This is how traditionally it's been. And we are going to see, as with many other types of cancer, the way we stage colorectal cancer, the way we talk about it, is probably going to change radically in the next 5-10 years as we start learning more about the genetics of it. But essentially, what most patients, when they ask me, well, what stage am I, it's hard for a lot of doctors to figure out what the staging is because it can be very nuanced. But in essence, what most patients are asking is I don't want to hear stage 4. I don't want to hear stage 4. And that's because we've known from like TV and the movies that stage 1 is early and maybe curable, and stage 4 is, oh my God, it's just like terrible. I should go get my affairs in order. And that's not necessarily true. Ultimately, it is going to be about what the biology of your tumor is, and we'll talk about that here in a second. But as an overview here, if the way we do the things that differentiates stage 4, for instance, from everything else is stage 4 is when the cancer has moved to other organs distant from the colon, so the liver and the lungs. Every other stage basically depends on the tumor size, and stage 3 is, did it go out into the lymph nodes? So if you had to lump these two, you would see that basically stage 1 and 2 are mostly about like the tumor size. Stage 3 is if there's any lymph node involvement, and stage 4 is if it's spread anywhere else. So how do you approach it? How do we use the staging to approach things? Well, stage 1, we typically think of as being very localized and focused within the organ itself. So, and not in the lymph nodes or anything like that, or not distant disease. So if you do the surgery to remove that piece of the intestine, that piece of the colon, in theory, you could cure the cancer. And then it becomes a little different when we talk about stage 2 and stage 3, because oftentimes we won't know if there's the lymph node involvement until we get the specimen out and send it to the pathologist, who then slices it up and looks under the microscope and looks at all the lymph nodes in that area. And it's at that point that we figure out, okay, does it look like there are lymph nodes involved with the colon cancer? And that will determine then, do you need chemotherapy? With stage 4 disease, typically at that point, we're thinking, okay, well, there's cancer all throughout the body, so let's treat the whole body. And that's when you see that most people will get upfront chemotherapy to kind of wash the system out and try and attack the cancer on all fronts throughout all of the different organs within the organism. So first steps first is the fact finding. We want to get our staging. So usually staging will take a form of CT scans, again, chest, abdomen, pelvis, to look at the liver and the lungs. If you have a rectal cancer, which is in the pelvis and fixed, that's where MRI shines a little bit better, because it actually gives us a better sense of how big the tumor is and if there are any lymph nodes that are enlarged that would be suspicious in that area. You can use other things like ultrasound, specifically in the rectum for rectal cancers. And then we can use things like PET scan, but PET scan is not a first line. It is more like as you're following somebody for cancer, you will maybe order a PET scan, but it's not a first line test. And one of the questions we always get is, well, why not just do a full body PET scan? It's the cancer scan. And, that's when we have to tell people, educate people that actually a PET scan is not a cancer scan. And what it's doing is it's trying to look for rapidly dividing cells. If you know that you have a cancer that is rapidly dividing and you see rapidly dividing cells, you can potentially make the inference that, well, this must be cancer. But in and of itself, it's just leading you in a direction. It is not a very specific test to tell you, okay, that's cancer. So if you had an infection in the body, for instance, where you're a cut on your arm where it's really trying to heal and you're creating a lot of rapid growth, you're going to see the PET scan light up there. It doesn't mean you have cancer in your cut. Other things that we would get would be labs to look at, what the liver function is like, especially if there's cancer in the liver. And then there are tumor markers. The one that is most common with colorectal cancer is called CEA. It's a protein that a lot of colon cancers make. If we find that it's high, then we would expect to see that go down as we do the treatments. But also, as we're going through our treatments and our surveillance, if we start seeing that number go back up, that would give us an indication that maybe there's something going on and we should go check. So not to bore you with more slides and data and things, but this is just to kind of, back up what Dr. Sheldon was saying, which is when you look at the percentage of cases that come to us just by stage, obviously people who are presenting typically have symptoms, so they might be at a higher stage. But what the graph down below shows you that if you can find cancers at an earlier stage, you're going to have a higher chance of survival, which of course is common sense. And this slide basically kind of shows more of the same, that as we have seen that new cases of colon and rectal cancer have gone down overall, we've also seen the death rate go down, and that may have something to do with the fact that more people are accepting of colonoscopies. We're finding polyps, we're getting rid of them before they can turn into a cancer, and so we're starting to see the incidence of that coming down. And similarly, because of that, we're seeing that patients who do have cancer, especially if they're found earlier, we're seeing a higher survival rate over after 5 years. So what is the staging takeaway? Ultimately, biology is king. What I always describe to patients is that if the patient and I both have stage 4 cancer, but the patient's cancer is extremely sensitive to chemotherapy and will just melt away at the whiff of it, but mine is very resistant to it. Ultimately, you would imagine that of the two of us, the patient who's very sensitive to chemotherapy and will melt it away will do better than me, for instance, even though we're both stage 4. So again, staging will tell you the location. It won't tell you about the biology in its current iteration. Our aims with all of this is to prolong life, but also to prolong quality of life. As one of my attendings used to say when I was training, is that you have to love your patient more than you hate cancer. Because we can do some pretty aggressive things and things that may not be in line with what the patient wants or really in line with a good quality of life for the patient. So just because we can do it doesn't mean we should, and that's where that tailored, discussion with patients comes into play. And the other thing is that we're trying to fight the cancer and not the tumor. And by that, I mean that just because you have say if you're stage 4 and you have a cancer in the colon, a lot of patients will say, well, why are you sending me to chemotherapy? Or why are you sending me to radiation or whatever? Why don't you just cut the thing out? And it's because, what we're trying to do is fight the cancer and not the organ alone. So what's the role of surgery? As a colorectal surgeon, there's a reason why it's called colorectal surgery, because we view the colon and the rectum as different organs, because they are. And the cancers that can develop there, we also treat differently. Similarly, the anus is a different organ and we treat anal cancer differently, but we're not going to talk about that today. So the question is, how much will you take out and will I miss what you take out? And, unfortunately, the colon, the organ of our specialty, is extremely dispensable. It's colon, it's nice if you got it, but if it's hurting you, you can just as well get rid of it and there will be adaptation. You will have to make, lifestyle changes and things, but it's not as bad as one would think. So just to recap the anatomy here, we're seeing, the colon comes in the forms of like the cecum, ascending colon, transverse colon, descending colon, and the sigmoid colon, and then we have the rectum and the pelvis, and Dr. Sheldon went over that expertly earlier. The key here is to look at the blood supply. If you see on the right side, there's a lot more red, and kind of to the middle there, to the upper left corner or upper right corner of our screen, I should say, there's like a lot less red. But ultimately, all the lymph nodes follow the blood supply. So what part of the colon we take will depend on the blood supply and the lymph nodes that are there. If you need a bag or an ostomy, ultimately, in the lay press, I think everything's referred to as a colostomy, but in reality, there's two different kinds of ostomies. There's an ileostomy, at least for intestinal surgery. There's an ileostomy and a colostomy. The ileostomy, as you can see here in this one picture, is where you take the small intestine and bring that out through the abdominal wall. And what's coming out is the food stuff before it has seen the colon, before the water has been absorbed by the Sheldon colon sponge. And so the output tends to be a little bit more liquid-like. A colostomy is where you bring out a piece of the colon to the outside world. And at that point, you might have more formed stools, kind of what you're more used to seeing from regular defecation. And both of those will go into a bag that's worn on the skin and can be emptied when the bag gets full. You may also hear reference to a loop ileostomy or loop colostomy, and that's that picture there on the right. We're basically just showing where you're bringing up a limb and then you're opening it, and it's the way you form the ostomy, where basically you actually have two barrels there instead of just the one sticking out. The key thing to realize is that ostomies aren't always permanent. More often than not, they're temporary. They're a way to bridge to the next stage of treatment. And the other thing is that to remember that ostomies are not what we probably remember from our parents or grandparents, or they are not. We make them differently. We have specialists with intrastomal therapy nurses who are expert at marking them, at maintaining them, at educating people. The appliances, the technology that we have now is radically different. So they don't leak as often. They have filters so they don't necessarily smell. In reality, if you came to our office and looked in the waiting room, you would not be able to tell which of the patients has an ostomy and which doesn't, unless they, did one of those Mardi Gras flashes at you and you saw it, and then you had to throw beads at them or something. May happen, hasn't yet, thankfully. And so, but these all play into your quality of life, into the considerations that we would need to make. So, once we get to, okay, we're going to do a surgery, well, how big will my incision be? Well, that depends on how much we have to take out, among other factors. But, for the most part, colorectal surgeons, especially here at Baystate, we use a minimally invasive approach. And that means laparoscopy, robot-assisted surgery. If it's in the rectum and you can do transanal resections with special instruments, which I'll show in a minute, we do that. If there's a polyp or some other lesion that you can take out through the colonoscope, our gastroenterologists have become very specialized in doing very special procedures to remove slightly bigger polyps and tumors without the need for surgery. As the director of robotic surgery here at Baystate, I would be remiss if I don't talk about kind of the frontiers. What are the newest things that we're doing? And we are doing pretty cutting edge things here at Baystate. And so right now, the main robot that's available that has been around for the last 25 years is the Da Vinci robot. And you can see in this picture here where basically you have a robot and an assistant at the patient bedside, and the surgeon or surgeons are sitting at a console and looking through the console and manipulating the arms of the robot. So I've been asked before, well, so are you really there doing the surgery, or some robot actually like R2D2 or something doing it? It's like, no, it's actually us doing it. We just have much finer control. And what the robot platform affords us is stereo vision. We get to see in 3D. As opposed to regular laparoscopy, the arms on the robot move, and I'm going to show some video here in a minute. They move just the way our hands would move. And so we get better visualization. We get much more precise fine motion. And so that's one of the helpful things. And here's an example of a patient where this is the colon that I took out of the patient, and these are the incisions that they had. And ultimately, we took out their whole colon and brought it out through that. The biggest incision they had was down, if you can see by their pubic bone, it was about 3 or 4 centimeters. And so recovery is pretty fast. A lot of patients have very minimal or very tolerable discomfort or pain after the surgery. And a lot of patients are going home a lot sooner after minimally invasive surgery. So I'm going to show a video because everybody wants to see video. So I'm just going to warn if somebody's squeamish, there isn't blood in this video or anything like that, but some people just don't like to see surgical pictures. But this is an example of robot-assisted surgery. This is an abdominal perineal resection where the goal was to remove the rectum and the anus and give the patient a permanent colostomy because they had a low rectal cancer. As you can see here, the instruments that we're using, are very precise. They can move just as our hands do. Even though this image that you're seeing is in 2D, in fact, what we're seeing at the console is in 3D because the camera that we use has 2 eyes to it. And just to show here, we have different instruments that can burn and cut things. Blood loss becomes very minimal because you can see the planes very nicely. And so you don't get into unnecessary planes or blood vessels that you don't need to. Here, I'm isolating the major vessel leading to the sigmoid colon and the rectum, the IMA or inferior mesenteric artery. And you can see like all the lymph nodes that would go along with that specimen. And here using this energy device to both cauterize and seal the vessel as well as cut it. And really visualizing a lot of the different structures that we would worry about in the retroperitoneum, like the ureters, or in this case, this was a female patient. So we saw the uterus earlier, there's ovaries. The chance of injuring pelvic nerves and sexual dysfunction, things like that, I think with minimally invasive surgery has become a lot less common because we're able to visualize these structures so well. And so, again, just to give you a sense here, I'm not going to run through the whole video, but to just give you a sense that you can really manipulate a lot of things. You really get good visualization, and we can do a lot more like precision work compared to what we could before with just regular laparoscopy. Similarly with transanal surgery, if we needed to remove polyps or larger polyps or some certain cancers from the rectum, we have specialized scopes that we can insert. And I know this looks like something out of the Spanish Inquisition, and it probably was inspired by that. I have no idea, but it's actually very effective where we can actually take polyps out that way. Now, looking to the future, looking at this as we get more minimally invasive, I really do have to kind of go to the past and as a student of history, and 1986 was memorable for a lot of things and infamous for a lot of things. And we might remember that was the year that the Chernobyl reactor blew up, but also the Challenger space shuttle blew up. We're thinking about this and we're feeling really old because Oprah Winfrey Show debuted in 1986, as did Phantom of the Opera. But in terms of sci-fi and advancements, that was the year that the Mir space station was launched. And also infamously, or not infamously, depending if you love this movie, it wasn't their best, but it was a decent movie. But Star Trek IV came out, The Voyage Home. And in this god-awful movie, they had to travel back in time to essentially save the whales. But the point being, in the 20th century, this is Bones. He's walking through a hospital and he comes across this scene.
What's the matter with you?
Kidney dialysis.
Dialysis? My God, what is this, the Dark Ages? Here, you swallow that. And if you have any problems, just call me.
What we don't see is later in the scene is that as they're leaving that hospital, this female patient is jumping up and down going, "I'm cured, I grew back my kidneys." So no matter what we think and how much we think we're on, we're so advanced, at some point we're going to look back and say, good Lord, we were just barbarians. But the next advancement for us right now is kind of getting even smaller. And this is a new platform that has now been out for maybe a couple of years. And I'm hoping to get it as our new as a new instrument at some point here at Baystate. But this is another example of the Da Vinci robot with basically minimally invasive surgery or even transanal surgery, where we have maybe the diameter of this is maybe a couple of inches, and you can see the two lenses on this camera there, and that's where we get the 3D vision from. And we're miniaturizing things more and more, and now through this one incision, you can have these multiple instruments that are fully articulated and can really move freely about the cabin and get work done. So this really is an amazing time to be a surgeon, but I'm sure there will be even more and better things yet to come. Once you've had your treatment for cancer, again, in the interest of time, I apologize, but ultimately what we want, there's the different cancer societies like NCCN, ASCRS, which is our society, or American Cancer Society. Each will recommend a way to do surveillance after you've had treatment for your cancer. And ultimately, the takeaway from this is that the highest chance for recurrence of colorectal cancer is in the first 2 years after the treatment. So that's why one of the hallmarks of all of these is that you'll see that you will have a lot more frequent kind of surveillance in the first 2 years. And if everything looks good and you're not finding any recurrences, you start spreading that out more and more up to 5 years. And after 5 years, if there's no recurrences, there's no other disease, you're essentially considered cured of the cancer. And this is just an example of how the ASCRS, which is the American Society of Colorectal Surgeons, this is what they recommend. And again, it's very similar to the NCCN guidelines. So ultimately, again, in fancy billboard fashion, the key here is to remember that prevention is still the key. Getting colonoscopy is extremely important. A lot of patients will want to do Cologuard and things like that, but ultimately, Cologuard is going to tell you that you have the cancer. And at that point, it's a little bit too late. We would like to have found it before then. So am I discouraging Cologuard use? No, not at all. Better that than nothing. Having said that, don't let Cologuard be the thing that says, or these other tests like CT, colonography, et cetera, be the thing that says, well, that's why I'm not going to get a colonoscopy. Colonoscopy is still the gold standard. So with that, I'm going to unshare my screen and thank everybody for your attention and maybe field some questions, I guess.
Wonderful. Thank you for those great presentations.
I think ultimately, like we were saying, prevention is the most important thing. And there's also this idea that, are you going to be too old to get a colonoscopy? And to that, I say, I know before the recommendation was, at age 75 or 80, maybe you can stop getting colonoscopies. But in reality, 70 is the new 50. We're seeing a lot of patients who are very active and robust and virile at age 70, which, I can only hope to be half that way. But we're even seeing patients in their 80s and 90s who are living very active, full lives. And if you're having symptoms, get a colonoscopy. Don't just, I'm too old to get it, or what's it going to make? It may make a difference. And absolutely.
To add to that, there's a question here. What is the age when colonoscopy is no longer recommended?
Oh, there you go.
I'm not seeing, I'm sorry to interject. I'm not seeing them. So thank you for reading that out.
Of course. So there are several, each of our societies, gastroenterologists in our society have somewhat different recommendations. And I think it's more than a mere number. Some people would say between 70 and 75, but what I say is if you are spry enough to tolerate a treatment, should they find a polyp or a cancer, that we should screen. So if there is somebody who is under 75 with life-threatening illness, it may not make sense to continue with screening. But if there is, someone who's 85 and they're otherwise healthy and fit, then I would continue with colonoscopies.
Yeah, I agree. I mean, I think age is only a number. Is that what you're saying? So it really I personally, I know what the societies say, but I personally would not put a cutoff. I would still recommend to my mom to go get a colonoscopy if she was having symptoms. It was her birthday yesterday. Happy birthday, Mom. But
Oh.
so yeah, I don't think there should be a cutoff, from that perspective, just by age alone.
There was another question here. Do patients ever go from a reversal of the ileostomy back to the bag? And the answer is yes, that's certainly possible. When we think about treatment, Dr. Kutayli alluded to this earlier. I never say his quotes as well as he does. I often try. But
I do have a lot of them.
you do. But the idea is that you want to maintain quality of life. And when we're talking about treatment for specifically rectal cancers in which there may be radiation, the colon, which is supposed to be a balloon, it's supposed to kind of billow, becomes more stiff. It moves like a pipe. And then you add surgery on top of that. The function after we reverse an ileostomy can sometimes be difficult, specifically in women. And sometimes that can lead to frequency of bowel movements, leakage of bowel movements, and even pain. And there are some people who do go back to the ileostomy. There's also a question of what do you think is the reason why colon cancer is more prevalent, particularly in the young? And I think, it's multifactorial. And I think certainly obesity is, a driver, inactivity, which often leads to obesity as probably one of the biggest drivers for this. There's also a question on the microbiome. It's referencing a family member seems to get sick more than I do. Could that have anything to do with the microbiome? Well, I am certainly a proponent of the theory of the microbiome. I think there's still a lot of research that needs to be done regarding this matter, but I certainly think that the balance of good and bad bacteria within the colon and the function that they serve, including in processing of vitamins and nutrients, could have a role in this. But I think also thinking about environmental factors, personal factors can also contribute to this.
So you just mentioned about the microbiome. Why are people younger than 50 years old getting more colon cancer? That's a great question. We don't know. The honest answer is nobody really knows. There's a lot of theories out there. But a lot of it, what we also know is that it's multifactorial. Cancer is never just one thing. And so when we think about environmental challenges, we think about, our dietary changes, our lifestyles have become maybe more sedentary. There's a whole host of things that have contributed. And I don't think anyone has the one right answer, but it is unfortunate in that in our line of work, we do see patients younger and younger with colon cancers. And that's why don't ignore symptoms. Like, it doesn't matter how old you are. If you're having symptoms and it's not just a one-off, like it's becoming persistent, do get checked by all means. Listen to your body. And then, what's the quality of life for somebody that has a colostomy in their daily life? So there's definitely an adjustment. There's a period of adaptation, but I think by and large, people do very well. People adapt very well to it. And oftentimes when patients have an issue with their ostomy, or they're unhappy with the ostomy, for the most part, it's because maybe we can find a better appliance for them. Just the same way that unfortunately I have to change sizes every so often, you still may need to also do the same and get remeasured for your ostomy, make sure you're getting the right appliance, because all of our bodies change over time. And, that becomes very important. But from a day-to-day perspective, when the bag gets full enough, you empty it, but you can have a very full life. I've had patients who have had ostomies who were having incontinence before. And then even though technically we talked about, hey, let's reverse your colostomy, they're like, no way. I've gotten a new lease on life. I'm not trapped at home because of my incontinence. Or I've had patients who, like, their lifestyle is that of kayaking and rock climbing and all sorts of outdoor activities. And they're like, I don't want to look over my shoulder looking for a bathroom. Me being able to empty the colostomy whenever I want has been like a boon. So there are so many stories out there that where people have actually had their lives improved by ostomy. So and I know you're going to hear a lot of different stories, but for the most part, we can get people through it. I did see there was a question. The hemorrhage after colonoscopy.
Yeah, two things to reflect. I often like to talk about a patient who I was seeing them for rectal cancer. And the first visit we were talking about, the possibility of an ileostomy, and this very young, vibrant lady looked at me and said, "I'd rather die. Doesn't matter what you tell me, I don't want an ostomy." And so we went through the process, as Dr. Kutayli alluded to, of staging the cancer, and they came back for their follow-up visit. We went through surgery and flew through surgery and got to the point where we were discussing reversal of the ileostomy. And she came to my clinic and she said, "Geez, doc, we're heading to the summer months. I've really gotten used to this ileostomy. I'd like to enjoy my summer. How about we postpone that surgery a little bit?" And so I think our patients can do great things, and it's a journey in which they are never alone on, because we have fantastic team of colorectal surgeons, but also ancillary staff in the office that can help in that process.
The stigma of ostomies, I think I'm hoping, is changing and will continue to change. The idea that somebody's, "I'd rather die than," whenever somebody says that to me, I say, okay, well, let's break that down. So I'm okay with not doing, with you, if you decide this is what you want to do, because I want to respect your wishes. But you have to be the one to look your child, grandchild, spouse in the eye and tell them that you not having an ostomy is more important to you than spending time with them. And I think putting things into perspective becomes very important. Like an ostomy, yes, it's not something anybody wakes up in the morning saying, "Hey, I wonder if I'm getting an ostomy today." And certainly as surgeons, we're not looking to just make ostomies for ostomy's sakes. But it's not the kind of sentence that it used to be. "Oh, I'm going to be trapped at home, and it's going to be leaking and stinky and all that." So
there's also a question that says it's talking about what I assume to be post-polypectomy hemorrhage. And it's a comment about how there was bleeding 2 days after a colonoscopy. And absolutely, can things happen? Sure. While colonoscopy is extraordinarily safe, the risks are very small. They're not zero. And absolutely, things like perforation or a hole in the colon can occur. And bleeding are probably two of the more common of the uncommon side effects. And I think typically the good news is that these can be treated with endoscopic procedures, meaning it's a repeat colonoscopy where we can control the bleeding after the procedure. And generally, we're not having to do invasive surgery. And so while I'm certainly not trying to minimize the impact that this has on patients, I think the benefit, the overwhelming benefit of colonoscopy outweighs the risks.
Yeah, absolutely. I mean, we always talk about, well, 99% of the time it's going to be safe. But if it happens to you, if you're in that 1% group, that's 100% to you. So I totally appreciate that. That's not something that we take lightly. It is uncommon, but it's also unfortunate when it happens. And there are a variety of reasons why that can happen. So I'm sorry that happened to this person. But by all means, do not let that scare you off from getting another colonoscopy if you need it, or if you need another procedure, because it really can be life-saving.
Okay. Well, thank you.
A comment that they were happy to be cared by our team, and we thank you very much. It really is a privilege to take care of patients. It really is, and we are seeing patients. We're seeing people who are at low points. Oftentimes, they're very vulnerable. It's hard. It can be overwhelming. And, it's our job to basically let them know that they're not alone, that even though it feels like they're out in the wilderness alone, they're not. And we have a whole team, like I showed that slide. It's a multidisciplinary approach. There's not a one of us, like there's no one person. Like people say to me, "Oh, you saved my life." No, I did not. Like I was just one of many people who contributed to that. And, as much as I would like to take the credit and all that, but, in reality, we're a team, and and at the head of that team is the patient. And, we just, whatever we can do, and it may not always work out the way we would want or they would want, but we always try to make it work, and we always try to get people through. And for the most part, we have more success stories, I think, than bad outcomes. But we try.
I think, my reflection, Dr. Kutayli has a few more years here than I do, but I mean, I am so extraordinarily.
Funny how I lost a lot of hair when you came on board. How did that?
I don't know if there's a correlation,
Fine.
but so extraordinarily lucky and fortunate to not only work with some amazing colleagues, but to really be able to serve the community in which Baystate serves. And I think really on all levels of care teams that we interact with, our front staff, our medical assistants, we couldn't take care of patients in the manner in which we do really without them. And we have such a tremendous system in place. And we're lucky as providers, but fortunate that our patients can be cared for by our larger team.
Yeah, and it doesn't matter how good of a technical procedure we do as surgeons. I mean, if we didn't have the amazing nursing staff that we do on the floor, if we didn't have our awesome office staff, like they're the ones that make us look good it really is a team effort. It really is.
Well, thank you both for your time and expertise. And we really appreciate you. And we hope you have a great night. And thank you to the audience for the great questions and for joining us.
Have a great night, everyone.